Good evening, everybody. We are here again with 5 cases today, and we are really going to be short of time. So I will just introduce my experts for today. That is Professor Wells and Murli Mohan sir, Rajan sir, rheumatologist Mithun, and Aparna as a radiologist, and our favorite Ritu madam for pathology. So these are the experts for today, and without any waste of time, I would start sharing my screens, and I'll be presenting case 1 and case 2. Hope my screen is visible and you are able to see that.
Yes.
Yes, we are.
Yeah, okay. So the first case is 164 years old lady from Alapura, that is Kerala area. She is a homemaker. She has hypertension and DLP, dyslipidemia, for which she is on treatment. She presented to me with cough for last 3 months. Her daughter brought her to me, telling that since her father passed away, the mother is slightly depressed and she was coughing a lot. She had cough which was dry in nature, no positional or diurnal variation. And what they are seeing is, even though she was coughing for long time, this particular cough is significantly worsened. And she had history of dust allergy. Now there were some non-specific complaint like muscle cramps and on exposure to cold, but otherwise there was no CTD stigmata and no weight loss or no loss of appetite. There was history of exposure to lovebirds, which were situated outside her home. If you ask me the duration, it is 4 years. Since the time the husband passed away, she started keeping the birds, and she goes and see them around 15 in number. There was no biomass exposure or anything else. Her vitals were stable. I could feel there were bilateral velcro type of crepitations, and there were no clubbing or anything else. Mithun, if you can just throw some light on this, that her ANA was 1 plus, dsDNA was 6, which was just positive, and AMA-M2 was positive. ESR was high, but she doesn't have any features of CTD, and her myositis panel was like this. If you can just say something about this, Mithun.
Okay. Ma'am, regarding this is a mild positive ANA. Usually immunofluorescence, what we consider in Indian population is 2 plus and above is considered significant. Therefore, if you see ANA, IFA alone, it is not very significant. And as expected, ANA blot also came as not very significant. This dsDNA in immunoblot is notorious to produce false positive, mild positive results. If it is strongly positive, like if we compare with the control, this is the last one is the control. If it is 2 plus and near 3 plus, it should be considered significant. 1 plus, in this case scenario, it is not significant. And coming to the myositis profile, usually myositis antibodies are mutually exclusive. That means if one antibody is strongly positive, other antibodies should be negative. In this case, you can see multiple autoantibody positivity. Therefore, we cannot get any importance or any information from this multiple antibody, mild antibody positivity. We have to consider as not significant.
Not significant. Yeah, that you are telling always, and I will remember that. So this is her. This was her pulmonary function test, and she could not do DLCO, or I forgot to do DLCO, and she has not yet turned up for the next visit. I will do that. But her FEV1 and FVC were like restrictive pattern. She desaturated from 97 to 92%, but she covered 420 meters with dyspnea box scale of 0. We did echo, and that was normal and no pulmonary hypertension. With that, I will stop sharing my screen, and we will go to Aparna for radiology.
Yeah, you're able to see the CT, right?
Yes, we are.
Yeah, so on the CT, we are seeing a lot of inhomogeneous attenuation in both lungs, lot of ground glass opacities, as well as some kind of lobular and geographic areas of sparing, probably air trapping. We don't have expiratory CT specifically, but it does look like areas of air trapping. In the upper lobes, there are few centrilobular nodules also, and some subpleural, some patchy kind of opacities. So that is a pattern diffusely involving upper lobes, lower lobes, centrally and peripherally. And in the bases, we see a little bit of fibrosis. So fibrosis is not a predominant component. It's only in few minimal areas of fibrosis. The extreme bases seem relatively less involved. There's no significant adenopathy and the pulmonary artery is not dilated. So overall HRCT pattern is, I think, kind of very typically fitting with the hypersensitivity pneumonitis. And although there's very small one pocket of fibrosis, I would say mainly it's like a non-fibrotic HP. I think it fits with the lovebirds also.
Yeah, okay. Okay. I think I will share my screen once more. So yeah, we did BAL. BAL was showing, I think, lymphocytosis, and there was a transbronchial lung biopsy. Ritu madam, if you can say.
Yeah. Yeah, hello, hi. So we are in this slide, we have on the left side the endobronchial biopsy, and on the right side there is the alveolar tissue bit which shows air trapping, as was seen on radiology also, and interstitial infiltrates and interstitial widening, which can be seen at this low power. So we have the next slide, which is the higher power. Next slide, please. Okay, next slide. In the higher power, they are showing, we can see that there is a cellular interstitial, no, the previous slide, please. So there's a cellular interstitial infiltrate. And if you go to the previous slide, yes, please. So on the slide on the left is a higher magnification. No,
This one, right?
no, next now. The first
There.
slide, this is the first slide. This is the third one. We go to the second one, which is showing the interstitial infiltrate, and at the high power on the left hand side, and on the right hand side, but I can see a large nodular area of fibrosis, and in the center of this fibrotic area there is peribronchular metaplasia. The periphery is showing still some alveolar air trapping and interstitium, but the center is showing fibrosis. So we go to the third slide, which is the next one. And the third slide, here we can see on the left hand side the peribronchular metaplasia nicely under high power surrounded by fibrous tissue. And the same is showing fibrosis on the Mason's trichrome stain. So I'm seeing definitely fibrosis. I haven't seen any granulomas. I'm seeing a cellular infiltrate. I am not seeing any lymphoid follicles. So the picture which we have, and whether there is honeycombing, could we call it in some of these large dilated areas, air spaces, whether we can go and call it as honeycombing, I'll have to look at it actually. So we have two features, fibrosis, peribronchular metaplasia, air trapping, and some query honeycombing. No fibroblastic foci seen so far, no lymphoid follicles seen so far. So this is what I would go to as of now.
So one of the question with the relative keep on asking me was, is it cancer? Is it cancer? Maybe they were scared of that. So this peribronchular metaplasia, do I need to follow it up, madam?
No, this is seen in interstitial lung abnormality.
Okay.
It is seen in fibrosing ILDs, in a variety of them. So this is definitely not cancerous because it is,
Sure.
yeah.
Okay, I told them that, but I just wanted to make sure that
Mhm.
I was right about it. And
Mhm.
yeah, so I actually that time, as shown, I felt it was fibrotic HP, to be honest. Even our radiologist reported it as a fibrotic HP, and we started her on steroids. Presently, she's only on 30 milligram of prednisolone, and this is her summary. So the question is it HP or NSIP? So there were some lymphocytes. Now those blue cells were lymphocytes, isn't it, Ritu madam?
Yeah, we have a mixed cellular and fibrotic, but the fibrosis, like as we see in NSIP, is usually diffuse and it follows the interstitial and the architecture. Here I'm seeing a nodular area of fibrosis and peribronchial metaplasia, which I don't see so often in fibrosing NSIP.
Sure.
And a lot of air trapping and query honeycombing also.
Yeah. So the questions
If
were
I had to
raised.
give
Yeah.
a differential, if I had to give a differential on
Yes.
biopsy here, then I would be putting connective tissue first and then a fibrotic HP second.
Yeah, I know. That is why I put this case that visit, and there were some small, as Mithun rightly said, that there were something which came positive. So I was confused whether it is CTD, ILD or HP, and there was lovebird exposure also. So do I need to add antifibrotics? And this question is specifically for Rajan sir and Athol Wells. I have asked it 100 times, but when my patient has got already fibrosis and patient was having symptoms for 3-4 years, and then we decide that progressive fibrotic ILD only on the basis of that given criteria when I do not have patient's baseline PFT. So why can't we start upfront antifibrotics? Like that is always I had always this particular argument. So over to you, all the experts. Murli sir, you can start because you have to leave early.
No, so I think the important thing here is how much of fibrosis there is and whether it's progressive or not. If you control the primary problem, which in this case I think is almost definitely HP, then I think
we lost you. I think, sir, we lost you. So maybe Rajan sir, you can carry on.
I think I got a bit more confused after the biopsy in this case. I was probably a little more clear or confident this was HP before the biopsy. And then I was suddenly had to take a step back after you biopsied this patient, Asmita.
Oh, I'm sorry.
I would not start an antifibrotic.
Okay.
See the response to prednisolone that you've begun. But I have I'm not sure what my working diagnosis would be here. Now that the biopsy has been done, it's a little unclear to me. Athol?
I enthusiastically echo this, but look, you're starting with a higher prevalence of HP, and of course, the pretest probabilities do influence likelihoods. I'll start by summarizing that I think HP may be more likely than not, but we actually need to be forensic about the elements of this. So you can get HP from outdoor bird exposures, that is recognized, but it's not as strong an antigen definition at all as a lot of antigen identification is in HP. So I would have said you have an indeterminate antigen status. And this is a situation where precipitants might actually establish that her immune system is recognizing bird antigen. It doesn't prove it, but it makes it a bit more plausible. So that's the first bit. The second bit is that I would use the word airway-centered interstitial fibrosis for what's on a biopsy. I haven't heard about cholesterol clefts. I haven't heard about granulomas. I haven't heard about small areas of organizing pneumonia that you see on biopsy, and a full house for HP has those three elements. You don't see the organizing pneumonia on a scan, of course. So you're describing airway-centered interstitial fibrosis. We don't know what the lymphocyte count was. A lymphocytosis could be 15% or 40%. We don't know if she's got reflux. We don't know what her smoking status was, because if she is a smoker, that makes HP less likely. And then when you come to the scan, I would have said you've got a very compelling 2-density scan. I'm not sure that you've got a 3-density scan. So at the end of all of that, before you did the biopsy, I was only at a working diagnosis at best of HP. And I think that sometimes you do play the odds and manage as that. The biopsy makes me uncertain. You've got airway-centered interstitial fibrosis. The differentials include reflux aspiration, HP, and a CTD. This minor serology positive, I hear loudly and clearly, you can make nothing of that, although it might be telling us there's a slight immune upregulation to give you that non-specific signal, and I don't know the answer to that. So I think that I don't see how you can manage as you would for HP. I mean, how you can do anything else. You've done what you need to do. It would be great to have positive avian precipitants for once this test would be telling us something. It would be telling us the antigen is actually more compelling as a possibility.
Okay.
So, Sujit, I think this is just saying in more words what you've just said.
Yeah. Murli sir.
Yeah, I'm sorry, I lost you all.
Yeah.
No, so for me, the background history, the appearance on the CT, HP is still the closest diagnosis. As Professor Wells says, it's nice to get a confirmation by looking at the precipitants. Whatever it is seems to be a reversible disease. So I'd start with, you've already started the steroids, which is great. MMF as the next step, as you're trying to reduce it. Antifibrotic, no, not at this point, not until I'm seeing progression, because it's still fairly minimal.
Yeah.
And reversing it, I think, will probably help.
Sure. Okay, I think I'm satisfied. And I also will go with the diagnosis of HP rather than this, because I would have done from the right lower lobe, ma'am, and where the fibrosis was maximum. So we will take it with pinch of salt and we will see with the repeat imaging. What do you say, sir? Right? Murli sir.
Yes, I agree. I think so.
So yeah,
treat
so that,
and review.
Yeah, treat and review.
But doing the HP panel, the precipitants would be very useful.
Actually, na sir, it is like that we have plenty of panels, but which is specific for our area, that is missing. Like
that is true. That is true.
Yeah.
But this thing, as far as I know, the panel includes Budgerigar's lovebirds. So
Sure.
I think it's useful.
Okay.
As Professor Wells was saying, it's not something we normally do. But when you're looking for additional evidence, having already done the biopsy, I think it's going to add to it.
Yeah, they can afford. I can do that.
I think it's worth just saying that a positive test is helpful. A negative test is not. Because sometimes precipitants are specific to individual birds. Sometimes they're species specific, and sometimes it will give you a generic bird trigger signal. So it's only helpful really if it's positive.
Yeah, I already told them to clean their house, and all exposure elimination has been already taken care of. So we'll move on to the second. Yes,
also,
sir?
just one thing, Asmita, how chronic, Athol mentioned those features of chronicity being absent.
Yes, sir.
But I recollect Aparna saying it was largely non-fibrotic HP on the scan. Would Aparna agree that this was predominantly non-fibrotic and very little fibrosis, Aparna?
Yes, sir. Only in the right lower lobe, there was a little bit of fibrosis. Most of it was not. So I was actually going to ask Dr. Asmita, where should the biopsy
Right lower lobe, right lower lobe.
So I guess that's why that biopsy specimen is showing so much fibrosis.
Yeah.
Ah, okay. And what's the lung function at DLCO, Asmita?
DLCO I have to do, sir. She didn't turn up for biopsy report.
Capacity?
She didn't turn up. Vital capacity 62%, and FEV1 of 69%.
Yeah, it's interesting. That's very restrictive, isn't it?
Yeah.
I mean, I think it would support HP if on a flow volume curve you had an element of airflow obstruction. And on that issue of looking at a scan and judging that there isn't fibrosis, I have to say in what we used to call subacute HP, where the assumption was it was non-fibrotic, a lot of these cases seem to have that permanent feature on the scan. Sure. So I would not be assuming yet that you will have major reversibility. Okay. And it bothers me there is that much fibrosis on a biopsy, actually.
Sure.
So fine fibrosis can look like inflammation sometimes. Okay. I think it's an HP that we most often stub our toes over that.
Should I make a consensus diagnosis of HP as of now, and we will move forward?
Well, I would say it's a working diagnosis.
Okay, working diagnosis.
We've got to be decisive. We can't be paralyzed, and we've got to accept. And if three categories: a working diagnosis, a confident working diagnosis, and a definite diagnosis, I would go for a working diagnosis.
I was going to say, taking from the terminology we use for the UIP, I was going to call this a probable HP.
Probable HP.
I suppose that's the same as your confidence. But before we leave this case, Dr. Asmita, compliments on being able to say Alapura so well. Most people can't manage it who are not from Kerala.
Yeah, I have learned. I have 3 Malayalis to deal with at home.
I echo what Murli said.
Yeah. So my kids and my husband is like almost Malayali. So husband is Malayali and kids are almost Malayali. That's why. So we'll move on to the second case. That, as sir told, I should not have disclosed the diagnosis, but it is interesting case and it is equally interesting. And I am sorry if people feel that it was not ILD. So this is a 19 years old man who is a medical student who presented to us with recurrent upper respiratory tract infection. He told us that he has smoking history and he does use vaping. And he had a patchy hair loss over posterior scalp, which was not diagnosed, but just we examined, and some burn marks, which I believe it's not specific, and I'll ignore that. Then the second complaint which he had is a spontaneous epistaxis. When he presented to us with dry cough, he had epistaxis also, high-grade fever, chills, headache, body pain, which looked like a viral infection, but because he gave vaping history, we were worried. And then there was one episode of loose stool. And nasal endoscopy was just bleeding area, and they told most probably it is a nail injury. His vitals were stable. He had fever and some tachycardia, but nothing else. We found there were bilateral bronchi. So this was his X-ray when he presented. Usually I don't show X-ray, but this X-ray was not looking like anything specific. So and he had monocytes of 16% with CRP of 224 and procal of only 0.29. Before starting antibiotics, we did bronchoscopy, and what we found was like his bronchoscopy were normal, except some nodular shadows in the right side lower bronchi. Bowel cultures, including gram stain and others, were negative. I didn't send a atypical panel or anything, and at the time of discharge, I did this. But this is his. And the day of discharge, prior to discharge, we did a pulmonary function test. This is what it was looking like. He had slightly higher DLCO and normal lung function test, I would say, but he had some dyspnea on walking. Other than that, he was fine. I will stop sharing, and Aparna, you can take over.
Yeah, so this is a CT. The only abnormality that we are seeing is corresponding to that big area of consolidation that we saw on the chest X-ray, and that is in the right lower lobe. It's almost like a roundish area of consolidation with little bit of ground glass. There are few areas of sparing inside it. The rest of the lungs are looking pretty normal. There is a right hilar small node was there. This one, and rest of it, there was no other significant adenopathy. Pulmonary artery was normal. Abdomen was also normal. So I don't have much experience with EVALI, but whatever I read up, it should be more diffuse and bilateral, and this is very unifocal, localized disease, and with the history of fever and everything, most likely it's like a pneumonia. Yeah, that's what I think.
Yeah. So what happened is, yeah, you stop sharing. So I will, yeah. So I also thought so, but he didn't improve with the normal kind of antibiotics, and I have to add him on steroids. And after addition of steroids, you can see, like we started him on broad spectrum antibiotics. I added even gram positive coverage also. I did echo for ruling out infective endocarditis. And the day when I started steroids, after that, everything started improving. And you might argue that even community acquired pneumonia steroids are helpful, but he improved with steroids. That is what I want to say. So if it was purely infection, he should have ideally worsened. So yes, I have done some kind of work on this, and then VAP use in 90 days. that was present. Pulmonary infiltrate on chest radiograph, yes. GGOs on chest X-ray, we can say that absence of pulmonary infection I proved by doing BAL, and absence of alternative plausible diagnosis, cardiac, rheumatologic, or neoplastic. So I believe he falls into confirmed case. He is the profile is usually 19 to 35 years. He was 19 years. Majority are male. He is male. He was generally healthy before presentation. Yes, he was perfectly fine. Clinical symptoms are 1 week of non-specific cough, dyspnea, respiratory distress. He was not in respiratory distress, but he was admitted in ICU when he came because of his tachypnea and tachycardia. And he didn't have hypoxia, but he had fever with GI symptoms. So imaging, Aparna, there are no criteria. It can be GGOs, it can be consolidation, it can be nodular opacities. Non-specific pathognomonic radiological findings are what is written. And BAL usually is advised to rule out infection. So this case I have put just to put out that whether it was bronchopneumonia or valley. And because he improved with steroids and I don't know whether it was there or not. And so sorry if it was not ILD case discussion, but I found it interesting. So I put.
Could it be like an organizing pneumonia?
Organizing
It's
pneumonia.
an OP,
Yeah. It happens in our, and because we have Professor Wells or somebody like as Aparna said, we do not have this particular cases more often in India, so we are not sure.
ANCA.
ANCAs, I don't think I had sent, but I will send because of epistaxis you are saying, right?
Yes.
And because DLCO was high. Yes. But I did BAL, but it was not hemorrhagic as such.
Can I say this is a fascinating case to discuss, but I am not sure what you're dealing with here. I may have missed stuff on the scan, but I thought what you had was a single solitary area that was very dense.
Yes.
And I worry about the label acute lung injury when what you've got is a very circumscribed single solitary area. And I would have said, firstly, that you might conclude that vaping had something to do with this, but I would also have had cancer in the equation. And I would still be saying that it is a little unusual for what we would call organizing pneumonia as an entity, as opposed to a reaction, because you've got a very large single mass without multifocal areas. You haven't demonstrated waxing and waning. I think a lymphocytosis, that's a feature with serial X-ray, which makes you think this is immunological. You can get organizing pneumonia around a malignancy, and what we don't yet know is whether an improvement on an X-ray is resolution of this mass-like entity. So I'm insecure at this stage, and I think the next thing coming to vaping, you've got to be insecure about the multiplicity of things reported with vaping. So it's not alveolar hemorrhage. I think it's unlikely to be an eosinophilic process because I think that would not be a single mass of this sort. It's not a classic HP. And then when you say lung injury, well, you can occasionally get focal lung injury, but that is rare. So whatever you call this, I think you're dealing with atypical features. And that means you can't use the unlikely argument to rule out things because whatever this is seems a bit unlikely. It would be nice to be able to see that you really have blown everything away on a scan, that you're not dealing with another process with an organizing pneumonia reaction. And I'm saying that because it is so focal, but quite spectacular. So my instincts are not to give this a label just yet. You're really managing as you would an organizing pneumonia. Isolated OP as single lesions does exist. Whether vaping is driving this, it's then a very weird lung injury, which is acute lung injury, which is actually a single focus, which is striking. So I'm groping for exactly how to designate this case. And since I am, I think it's time somebody else who might be able to do better than I can stepped into the picture.
Murli sir, you would like to comment something?
No, I'm completely lost. Just common things occurring commonly, I'd say infection.
Yeah.
And you don't always have to pick it up on a scan. The DLCO worries me, and I'm just wondering if it makes sense, especially given that Professor Wells said malignancy to be ruled out, whether we should do a biopsy straight away.
But it resolved on X-ray, na? Like I can do a repeat CT scan, but I will.
I think you better do a repeat CT because whatever this is unusual.
Okay.
And we've been trapped by this.
Sure.
You can actually do a biopsy COP, but actually with an isolated lesion that is quite striking with OP surrounding a malignancy, or a lymphoma, which actually is getting a response to steroid as they can. There's enough about this that I don't think making a most likely diagnosis is going to be enough, that if you get this wrong, you really mess up management. Sure. Okay. So this is where you draw a deep breath in and you actually get tissue. I completely agree with that. And I also would have been inclined to go for infection as the single most likely thing doing this. It's unusual, isn't it? But nonetheless, whatever this is unusual. So I like the common things that occur commonly approach very much in this sort of setting.
Rajan sir, anything you want to add, or we'll move to third case?
No, I've seen EVALI, and I think I've never seen EVALI like this.
Okay.
And it is unusual. But you didn't have an X-ray that showed resolution after antibiotics?
I had, no? I showed 1 second.
Did you show complete resolution? I think just looking hard at that, it gives you a better sense. No, I don't think there is, but look, if I hadn't seen the scan, I would have been very comfortable looking at the X-rays and saying this is likely to be infection.
Yeah.
To a point where you're quite confident. When you look at the scan, I completely go along with infection as the single most likely thing, but the scan does bother me.
Okay. So I'll do 6 weeks scan. After 6 weeks, repeat scan, and we'll see if biopsy is possible.
Well, I mean, it may well be that doing the scan, you've got more time. It does resolve completely, and it does end all argument.
Okay. So if it resolves completely, no need of scan.
Yes. No. I would just say, look, if this is something else at the center of an OP process, and a scan is telling you that you've got features there, because the X-ray doesn't show complete resolution, does it? So I think being very forensic about this is going to be the right approach. And my guess is also that it's probably more than 70% likely that this is an infection manifestation.
Okay.
And the X-ray, Asmita, would also take much more time to resolve, right?
Yep.
So I was just wondering, if we hadn't given steroids, what do you think would have happened?
Yeah.
I don't know. I was like, I want immediate results, kind of.
But I think it's fair to say that the histology of organizing pneumonia happens in infective pneumonia. The difference is you find the infection.
Yes. Yeah.
One thing which is missing in me is patience. I can say that. Okay, we'll move on to third case. This case belongs to Shobha madam, and I'll just share my slides and madam can present. Yeah.
Good evening. The patient is 50-year-old male from Alappuzha, again, works in the Water Authority department, and he's a known smoker. History of dyslipidemia on treatment. He presented to the medical oncology department of our hospital in 22 with complaints of abdominal pain and weight loss. And prior workup showed abdomen had a periumbilical mass lesion. CT abdomen showed relatively large, well-defined, heterogeneous, enhancing soft tissue mass lesion connected to the mesentery, and there was multiple supradiaphragmatic and infradiaphragmatic lymph nodes, which included hilar lymph nodes also. A CT-guided biopsy from the abdominal mass confirmed lymphoproliferative disorder. IHC showed positive for CD20 and BCL2, and findings of marginal zone lymphoma was arrived at. And as a part of staging for lymphoma, a PET CT was done in 22 October, which showed lymph node lesions, abnormal diffuse FDG avidity in the liver, spleen, and the marrow, and staging was stage 4, non-Hodgkin's lymphoma, and he underwent chemotherapy with rituximab and bendamustine. 6 cycles were given, and he finished chemo on the March 23. A follow-up PET CT was done the next month, which showed metabolic resolution with reduction in size of bilateral hilar and abdominal lymph node lesions, and significant reduction in the extent of that big mass in the abdomen, and metabolic resolution of the FDG avid lesions of the liver, spleen, and bone marrow. So PET CT was suggestive of good response to treatment after 1 month. In September 23, there is a history that he was admitted in a local hospital with bronchopneumonia, which resolved with antibiotics. And as a part of further follow-up, he underwent another PET CT after about a year. At that time, he did not come out with any symptoms, but the PET CT showed an increase in the size of multiple supra and infradiaphragmatic lymph nodes, which are all now FDG avid, and there were new lymph nodes also. There was metabolically active bulky tonsils, diffuse involvement of the spleen, liver, diffuse involvement of the FDG avidity of the marrow, and the chest lungs showed bilateral, multiple, metabolically active, spiculated soft tissue and ground glass nodules, and the whole PET CT was suggestive of relapsed lymphoma. So what the medical oncology department discussed, and they needed a biopsy confirmation of a relapsed lymphoma, and the liver biopsy was done, which showed granulomatous inflammation. That is how we came to the department, our department. And when we went into detail, he had history of intermittent dry cough since 4 months, otherwise no weight loss or any night sweats or anything. And this was the X-ray which showed reticulonodular shadows. We went ahead with a bronchoscopy which showed classic cobblestone appearance of the entire tracheobronchial tree mucosa, and a linear rebus did not reveal any mediastinal adenopathy. We did a cryobiopsy, endobronchial mucosa from the nodular lesions, as well as multiple transbronchial biopsies were done, and BAL was taken from the right upper lobe. BAL was negative for TB. That was my main concern. I wanted to rule out TB. So smear AFB was negative. My MTB gene expert was negative. There was no growth in AFB culture, BAL, fungal, everything was negative. And it was a predominant lymphocyte, predominant fluid. And biopsy was,
Yeah, so the biopsy is a nice adequate biopsy, and showing multiple non-caseating epithelioid cell granulomas, which are discrete, which are showing the presence of these multinucleated giant cells. And in the giant cells, we can appreciate the lamellated Schaumann body looking calcified in the center of one granuloma. So therefore, looking at this picture and the number of multinucleated giant cells also seen separately in the center, the possibility of because we can get Schaumann body and these discrete granulomas. Madam, did we rule out tuberculosis occurrence?
Yes.
Reactivation of tuberculosis in this patient. If so, again, we'll have the differential diagnosis of tuberculosis and sarcoidosis, and we'll have to work it up.
Yeah, we ruled out by doing microbiological exam.
Okay.
So we went ahead with the biochemistry. Serum ACE level was high, calcium was normal, manto was negative, SGOT, SGPT was normal, but alkaline phosphatase was high as we expected, creatinine normal, and an ophthalmology consultation showed no evidence of sarcoid. Coming to the lung function, the ratio 87, FVC was reduced to 67%, DLCO was low borderline. 6-minute walk test I have not done because he did not complain of dyspnea or any significant respiratory complaints. ECG was normal, echo did not reveal any PAH. And yeah, these are my questions. Diagnosis and suggested management plan, and what is the prognosis of this particular case? Radiology, do we have?
Aparna?
Ma'am, I have only the 2022 and 23, ma'am. I don't have the present CT.
Oh my God, that has classic features actually. 20.
I didn't realize. I thought only those two were there.
Oh.
But can I just tell, we have seen some cases of these sarcoid-like reactions coming in malignancy patients, lymphoma patients after treatment. So I think it is something like that, the way you're describing. We have seen few cases like that. They're called sarcoid-like reactions.
Yeah, it'd be good to see, good to hear Athol's views because they run a sarcoid clinic at the Brompton. Athol, this must be something you see also fairly commonly.
I think the words we use to describe the diagnosis are important here because it's a distinction between benign and malignant lymphogranulomatosis or granulomatous disease. And we know that in nodular sclerosing Hodgkin's, for example, in 15% of cases, there will be granulomas in organs not involved by lymphoma. I don't think we're talking about drainage from malignancy granulomatous change. That created major confusion. And so what we're saying is, have we got enough here to say this is true blue sarcoid as an association with a lymphoma? Is this more a granulomatous response that is more systemic, somehow triggered by a lymphoma? And what would you do to actually designate this? Well, a scan, very helpful. I do think if you've got classic sarcoid on a scan, you've done a biopsy, you don't find lymphoma in the mix, you will say this is sarcoid, and you will accept that you get sarcoid in solid tumors also. There's a number of these cases I see over the years. They have got true blue sarcoid. The lung features are not cancer features, and you generally, though, go to a biopsy, and in that case, you manage as for sarcoid. And I think the difference is you don't seem to see the nasty fibrotic sarcoid in this variant of sarcoid. They often do very well. I think what you do is be sure that when you do treat a sarcoid, you are blowing away the signal and that there isn't some sort of recrudescence of lymphoma in the background that is somehow triggering an ongoing granulomatous response. But I would call this sarcoid on what I've heard, and I would manage as for sarcoid on what I've heard, but maybe my monitoring of disease behavior would be rather tight from here. And that's about all I think I can say, Sujit, that I think in the end, it is most helpful to say that there is both lymphoma and sarcoid most likely, that I would be coming back and seeing if that separation was still helpful in 6 to 12 months' time.
You are muted, sir.
Sorry, what percentage of your lymphoma patients have a sarcoid-like reaction, Athol?
Well, I'm really I suspect it depends on lymphoma to lymphoma. And by the way, I'd be interested in going back to the lymphoma biopsy to see if there's a granulomatous element mixed in with the initial biopsy. I think that would be interesting. My figure is more for nodular sclerosing Hodgkin's, 15%, having granulomas in organs not involved by lymphoma. So that's a fairly significant amount. Now, whether all of that 15% actually translate to a classic pulmonary CT sarcoid entity with no evidence of lymphoma on the biopsies, and you took multiple biopsies, I saw. I'm not sure that it's as high as 15%, actually give you the full-blown clinical picture of sarcoid. But it's enough there, isn't it, that you really need to be on your guard. And I have lost count of the number of patients, each of them isolated, but a steady trickle, where they're told by oncologists that their cancer's gone wild, and then it's found that they've got sarcoid. And one or two patients went online, read about sarcoid, and told their oncologists they had to come up to a sarcoid clinic, and they were right.
Ritu, madam, you wanted to say something. Yeah.
I wanted to ask Dr. Athol, would a CD4, CD8, and CD15 and 30 be done at this stage be of any help?
I don't know the answer to that. I don't think we have a sense of these tests when you're trying to distinguish between benign and malignant lymphogranulomatosis. So sarcoid versus a lymphoma. And I'm not sure about that. So you might have lymphoma in the background in some way driving this process and still active. Now, would those markers tell you that? I don't know. I mean, I'm a bit suspicious of precision in cases like this. I tend to trust serial disease behavior a bit more. So you make a diagnosis, you manage this for sarcoid. If this is sarcoid, I strongly suspect that everything will be blown away by therapy. And then you'll be that much secure coming back to the case and saying, is this separation we are making endorsed by disease behavior with time? Rather than a one-off evaluation of a marker.
You meant IHC, Ritu madam, IHC on biopsy, right?
Yeah.
Lymphoma, IHC for lymphoma panel on the same histopathology slide, whether it will be helpful or not. Okay.
Yeah.
But look, what I will say is that we have got a lot of value sending tissue not thought to be lymphoma to really expert evaluation in our centre across the road to a hospital that is a specialist cancer hospital with a lymphoma guru that is a pathologist. And so I would have tended to want to send biopsies where I work just to say, can you actually see there is a form of lymphoma that is somehow in the tissue with staining of some kind that is driving this? Now, my strong suspicion is you'll get a negative for that. But sometimes it's best to go for the best.
Okay.
You meant negative for that in this case, Athol?
Sorry?
You said your strong suspicion you'll get a negative was for this case.
But yes, for this actually being lymphoma in the lungs, fooling you on a biopsy because you haven't done the right stains. I think a lot depends on the CT phenotype. We've heard it's classic for sarcoid. In my experience, the occult lymphoma doesn't tend to look classic for sarcoid on a scan.
Yeah.
I was wondering if it's worth doing a bone marrow and looking for lymphoma there. His bone marrow is lit up on the PET. So, if he has both simultaneously, then it's worth looking at the bone marrow.
That's a very important suggestion, I think. Look, you're in a situation where you've got two treatable disorders, aren't you? And you could mess up in a major way if they're both there together and we actually are saying that this is really just sarcoid in isolation. And I think if you have got sarcoid infiltrating the bone marrow, it would be nice to know that as well, wouldn't it?
Okay.
Dr. Asmita, with your permission, I'm going to go away.
Sure, sir.
Thank you so much.
Thank you for being part.
We will miss you, Murali, but when you have to act in a play, which I understand you said you did.
Shobha madam, you want to ask something?
About treatment part.
Well, no, I think it's important to be decisive because you're going to use response to therapy and actually restaging the situation after you have treated. So this is a case where you don't mess around, I think. You reverse this quite vigorously. You see early that it's melting away, which it might well, and when you see that, you bring the dose of steroid down very quickly. But what you don't do is go half-heartedly into this because you're not sure. So I don't use methylpred on the whole as initial sarcoid therapy unless it's cardiac or neurosarcoid. I think I might be wanting to see quite quickly, but I also understand logistically often you have to go with oral steroid. I would go with a fairly hefty dose for a fortnight. Establish fast that this is melting away. And then if you see it melting away, you come down quite quickly to a maintenance dose, target 7.5. You don't do it in one step, but you do it weekly reductions over maybe a month, and then you're restaging.
Any need for any additional agent other than steroids?
Absolutely not as a starting point.
Okay.
And I'll tell you why I say that. Firstly, I don't think these cases you get nasty fibrosis supervening generally. I don't know what it is about the cancer-associated sarcoid cases, but I don't see nasty fibrotic sarcoid, and I do see reversibility being a big deal. So that being the case, I think adding an immunosuppressive drug in a patient with a malignancy is not something I like the idea of. And then secondly, you've got infiltration of bone marrow, so whether it's sarcoid or there is lymphoma, and an immunosuppressive agent with bone marrow suppression. Now, if it's all sarcoid, I don't think you'll get a better short-term response with the second-line agent, but if it isn't all sarcoid, an immunosuppressive drug at this point might just cause more harm than good, I suspect. And with that, I would add, we know with lymphoma that on average there's an immunoincompetence associated with it when it comes to infection. And that's why I say short, sharp steroid, high dose, but get the dose down. Adding a drug that gives you greater likelihood of infection at this point, you have to have a pretty good reason to do that. And I'm not sure I see that in this case.
Okay, thank you.
Right. So this is a short case. 66-year-old male businessman living in Mumbai, never smoker, and met me a fortnight ago. He is overweight. Routine chest X-ray had an abnormal right lower zone haziness. Advised to start 2 antibiotics by his GP. No fever, no leukocytosis. Chest X-ray of 2017 was normal. One second. I don't think this is the case, Asmita. Just a second. I think I had the. Just a second. Can I just see if I can find this? Just a second. Sorry about this, just a minute. I think I have the case. Smita, can I share screen? I think I shared Mr. PB with you, and I actually had PG.
Yeah, you share.
That's where the confusion happened. One second. Can you see it?
Not yet. I don't see it, Sujit, but I was looking forward to that first case in inhaled or were you treating moth infestation of his lungs, perhaps?
Yeah. Now we can see.
You can see it now?
Yes.
I'm so sorry about that. So this was a 45-year-old male married stock trader living in Mumbai. 16 pack years, quit about 2 years ago. So ex-smoker. Paroxysmal dyspnea in the mornings for the last 6 months. And his whole history is since 6 months. He's complaining of inability to walk long distances or lift heavy weights in the last 6 months. No autoimmune symptoms. In 2016, he was diagnosed as pulmonary TB. I put it in inverted commas because a biopsy of a right lower lobe lung nodule had a gene expert that was positive, but the AFB cultures were negative at 6 weeks. And the histopathology in 2016 was suggestive of caseating granulomas. I don't have those slides. So it was in another city. He also has SVT. Since the last 5 years, he's on verapamil. His father has COPD. He has a few crackles in the chest. I got an ophthal review after seeing him and the scans. There was no uveitis. And the chest X-ray showed bilateral fine reticularity just as in 2015. And so if we can have the CT, then I can tell you what my queries are here.
You stop sharing, sir.
Yeah.
Upper.
Yes. So this is the CT, which is showing the remarkable finding that we are seeing is this interlobular septal thickening, which is diffusely seen in both lungs. Most of it is looking smooth, but some areas it's looking slightly nodular, but that is the predominant finding that we're seeing, the interlobular septal thickening, which is diffusely seen. We do see some nodules, many of which are like these, but many of them are calcified. And I changed the window. We can see that they're all calcified, multiple tiny calcified nodules. And there's a very little bit of pleural thickening on the right side, and that also shows a few calcific foci. So maybe with that history of TB in 2016, all these could be that these are granulomas, and that pleura is also showing that thickening. So those may be part of TB suppose we want to keep them separate. So the other finding that was significant looking was that his main pulmonary artery is dilated. It's around 32 millimeters, but not much of RA-RV dilatation. Maybe RA slightly, but RV definitely does not look dilated. And with the PND history, I was just looking at the heart. Again, left ventricle doesn't look much dilated. Left atrium also, obviously, echo you must have done, but these are not really looking dilated. Abdomen, I did not see anything significant. There wasn't any significant lymphadenopathy also. So the main finding for me was the interlobular septal thickening, which I thought was mostly smooth, but maybe some areas were looking little nodular. Some mild nodularity are there along the fissures also. So with that PND history, like, is it like edema? But then you're saying it's there from 2015. That is also a bit confusing. And another thing is when the pulmonary artery is dilated and we have interlobular septal thickening, another thing that we consider would be PVOD, but again, that does not fit with the clinical history and this long-standing from 2015. Can it be sarcoid with that minimal nodularity, but it's not having the typical peribronchovascular, but it is the interlobular septal thickening that is there. So these are my thoughts. I'm not sure what it is.
There was some right lower lobe nodule.
Yes, sir. That is also calcified, this one.
And that's, yeah, regressed. That right lower lobe nodule that was biopsied showed the caseating granuloma.
Yeah.
Was reported by my CT radiologist, Aparna, as having regressed.
Yep.
And there was some mild improvement in the ground glass and septal thickening, but with significant residual lesions. And he said this was an unusual ILD with septal thickening and ground glass opacities, like you said. So we
Aparna,
yes.
I'll give you the lung
is there
function.
a pericardial if you is the pericardium all right? Is there any calcification of pericardium or anything?
No.
Nothing, no?
Yeah.
Okay.
No.
Fine. Yes, sir.
Give you if I can share the screen, I can just give you the lung functions. I'll just share a second. Yeah. Can you see it?
Yes.
Yeah. So in 2015, his vital capacity was 1.80. DLCO was quite low, actually. I don't know why nothing was done or investigated at that time. And that's his 6-minute walk distance. And this is now when he met me for the first time with this 6-month history of dyspnea. He's not dropped much considering it's 9 years, is what I felt. DLCO had dropped slightly, but he's symptomatic. His walk test is good. His echo is pretty fine. So with this 6-month history, my questions were really, should we biopsy or continue to monitor? Like, he went into hibernation for 9 years now. I thought we should biopsy. That was my thought. But what biopsy should we do? Transbronchial or cryo? That's all. I'd really like your thoughts on this.
I have to say our 4 cases are wonderful discussion cases. And I would just stand back a bit and say, what do we have in this case? So we have somebody who's young,
yeah,
who's having a paroxysmal process,
yes,
creating dyspnea. And immediately when you go through the CT likelihoods, I am then wondering what else in the picture might actually swing you towards one of the possibilities. And cardiac sarcoid would be high on my list, but then that's only because the other things won't be paroxysmal, and you have got a history of a rhythm disturbance there. So
yes,
maybe this is just coincidence, but one distrusts coincidence. So my anticipation, for a number of reasons, is you're going to end up with sarcoid at the end of this, but you're certainly not going to make a diagnosis without a biopsy procedure here. Then we take 1 or 2 other elements of this. And what struck me was the gas transfer being normal with an FVC of 40%.
yeah.
And I think you said he was challenged in his BMI.
Yeah.
I'm using correct language here, you understand. I think that almost certainly means there's an extra pulmonic element that is driving a good part of the FVC. You can't have an interstitial element driving an FVC of 40% with a DLCO of 84%.
Right.
And so that's major extrapulmonic restriction. Now, I don't want to build a castle in the air, but I would say respiratory muscle weakness, cardiac involvement, you'd have an inflammatory myopathy in the picture. But by the way, the scan doesn't really look like that at all. But maybe you would say sarcoid and inflammatory myopathy have an association, so you do the inflammatory myopathy panel here. Then you're looking at a scan where you think, I'm not sure you got a scan 15 years ago. If you did, though, and the septal thickening was there then a whole lot of things are wildly unlikely, aren't they? And sarcoid suddenly becomes incredibly attractive as a diagnosis with that sort of duration. Could there be a pulmonary vascular element? Well, you don't think so on echo, and I don't think so when I look at his 6-minute walk distance, minor desaturation, and a gas transfer that was actually normal. And now is slightly reduced, but by the way, hugely better than it should be. for the FVC. So that's the sort of opposite of a vascular profile, isn't it? It's a mirror image. And I think this pulmonary artery dilation sign can be very helpful if you've got a highish pre-CT suspicion of a vascular problem. I think you get a lot of signal of enlarged pulmonary arteries that don't mean things in the end if you're not actually using it in a disciplined way. So when I pull it all together, I think this is most likely to be sarcoid. And it would seem to me that the first step is a cardiac MRI. And you're not going to biopsy the heart, of course, but if you've really got paroxysmal breathlessness, you do need to know what's going on there. And then if you're managing cardiac sarcoid, I think it's even more important to have the biopsy. You may be confident about the diagnosis, but not every doctor interacting with this patient will be. Sarcoid often behaves in unusual ways, and you end up saying, oh, I wish we had got a biopsy. So then you might say, what's the yield? Well, the lymph nodes, I think, were not that enlarged. You have got a nodular element. I think you would have quite a high yield going to a lung biopsy procedure. But maybe if you find cardiac abnormalities saying that cardiac sarcoid is likely, you'll do a PET scan, and maybe the PET scan will actually give you the best source to do a diagnosis. Maybe you'll discover that a simple EBUS is what is going to give you a yield. So just to summarize, you need a biopsy, but I think going to the heart first is probably the right answer, because you will get a PET scan and that will help you pick a biopsy site. If you really don't get the signal, I suppose I'd do one of these multi-purpose BAL transbronchial stroke cryobiopsy if it takes your fancy, and maybe do an EBUS in the same procedure. But I mean, what tests you've got, how easily you can link them together, what the patient thinks about risks of pneumothoraces. We both know, Sujit, that this is actually all up for negotiation, isn't it? But we agree you've got to have a biopsy. And do you agree that sarcoid is the single most likely diagnosis here?
Yeah, it was the most likely diagnosis in my mind, and I was also worried about the cardiac sarcoid element. I was keen to know from you the order of investigation, and I like that order. Cardiac MRI, if all okay there, go to the PET and biopsy.
I have one doubt. So, like sometimes we do a PET MRI. So, can it replace cardiac MRI?
No, I don't think it can. I really think you get so much more out of the two things together. So PET is about inflammation primarily, but if you've got rubidium, you can get a scar tissue signal, which is fairly reliable. Do you get a signal where you look at the nature of the signal and say that's likely to be pathognomonic of sarcoid? And that becomes a complex argument. MRI is more about damage. I mean, you get a lot of PET inflammation where you don't get an MRI inflammation signal. The other thing doesn't work. Basically, if you've got MRI edema on stir imaging, you will see major PET signal. So you really want the combo of damage, and that's about rhythm disturbance, and it's about the sarcoid is more dangerous, and the damage is driving life-threatening ventricular rhythm disturbance versus likely reversibility, and you put them together. Now, if you've got a way of doing a PET MRI and you get two for the price of one, that's great. But I have to put my hand up and say, I don't know, because I do not.
No, I was just asking. We'll move on to the last case. You want me to share the screen, sir?
Yes.
Yeah, okay.
Sorry for mistaking PG. Actually, this case, PG with PB.
Yeah,
the camphor case will come for follow-up one of these days.
This is correct case, right?
Yeah, I would encourage you to present the inhaled camphor case. And maybe you'll find moths when you do the biopsy.
Okay, last case.
This is the last case for today. It's a follow-up case. We've discussed it, but because Athol was not one of the clinicians in that discussion, I wanted to bring it up. It's a fascinating patient for discussion. This gentleman is 68, Athol, and 2 children, never smoker. He's a retired, very calm, composed man coming into the clinic. He has cough and very mild breathlessness for the last 8 months. Nothing autoimmune in terms of symptoms, but he had an ANA of 1 in 320, nucleoplasm speckled with condensed chromosomes. Repeat ANA when we did was 1 in 80. The CCP-RF were negative, ACE okay, the blood test, the myositis antibodies were negative. The reason we got him to MDD was his history, spine TB, long ago. As you can see, central retinal vein occlusion in 2017, for which he needed steroids for 2 months. A glaucoma, which needed trabeculectomy in August 2018, and he's lost his eyesight in the right eye since that. Family history, elder brother with ILD, which was called IPAF in Australia. Ian Glasspool was managing him. And he had a lung transplant in June 22, and that gentleman expired 5 months ago. So he's quite traumatized by his brother dying post-transplant. Next slide. And these were his lung functions, that's all, because he's been following his lung functions very, very closely, and even more closely during the COVID years. And I saw him first earlier this year, and I told him that with the familial nature of his case, he may need a drug. Ian Glasspool in Australia said he should be on antifibrotics. I was not that gung-ho about the antifibrotic as much as immunomodulation because of that ANA in 1 in 320. And his scans, Bhavin Jankari had seen them, were suggestive of sarcoid. Bhavin said this is not IPF. And so we discussed this in MDD about a month or 2 months ago, you remember, Asmita? And
Yes.
since then, I got a fresh lung function, October 24. And this is where he is. He doesn't want to do anything. But he still keeps coming for follow-up. And these are his walk tests. Next slide. And maybe, Aparna, you can show us the scans.
Yeah, sure.
Yeah, so you have a lot of scans. Yeah.
Yeah, I have 4 CTs here. I just put the same level. I'll scroll in a minute. So this is February 22, this is May 22, and this one is June 23, and this is August 24. I just mainly put it up just to show that I think there is definitely progression in the fibrosis. If you see, these are almost the same sections. Over time, and definitely the present one is showing definite progression in the fibrosis. I did not actually listen to when Dr. Bhavin said that it was sarcoid.
His initial scans, earlier this year, Aparna was convinced. I mean, he said this is highly likely to be sarcoid. You should biopsy, Sujit. But then he got this opinion from Australia that it doesn't look anything like sarcoid, and he should be on an antifibrotic. And then I met that Australian chest physician at a meeting recently, and he said, yeah, it's difficult to say what's going on. And then I told him that I would like Professor Wells' opinion on this patient. And so he was happy that Athol was also going to see these scans.
Well, I think looking at the scans, we do have to instantly go back to some clinical features, don't we?
Yeah.
And while I have a view on what we're seeing on the scans, I think Sujit, if you've got more to say,
just the next slide. I can just put up the question because this was discussed, and a lot of people in the last MDD suggested we give him a trial of steroid. But Smita, do you have my last slide?
Yeah, but
came back.
Okay,
I'll
I'll
stop
share.
sharing. Yeah.
Yeah, okay.
But the patient came back to the clinic and said, I'm not taking steroid because if I lose sight because of glaucoma in my other eye, that's not a quality of life I'm going to accept. Next slide. Sorry, you have that lastly? Yeah. So the ophthalmologist said, look, I will monitor the IOPs. You can start steroid. But the patient was not keen to go down that route. He's unwilling for biopsy. Antifibrotics advised in Melbourne. He's against that as well. We repeated his autoimmune profile because that was advised in the last MDD, and the ANA was 1 in 1,000. So, I just don't know what's going on here. And so he's just happy to come and be monitored, but he doesn't want to rock the boat. So we have a decision on what to do because he has a fairly strong view that he doesn't want immunomodulation. Would one push for steroids here? What is your view, Athol?
Can we go back to the lung function first?
Yeah.
So whatever.
Sorry. So this was, go back, Asmita, that's what I want. Yeah. So this was the fresh autoimmune workup, ANA 1 in 1,000, COO borderline positive. I don't know if Mithun has a thought here. Anchor MPOPR3 negative. And the PFTs?
Just go back to that.
PFTs.
Lung function. You had the lung function set up.
Yeah. This is where the lung function is. Yeah.
And his age is early 60s, I think you said.
68.
68.
Go to the first slide and come back here, Asmita. Thank you. So 68, and this was his autoimmune workup, ANA 1 in 320 last year.
Got that. So you've got the ANA.
Next slide, Asmita. Yeah.
Okay. What do I get out of this? Well, in 2022, the DLCO was 28%, and it's now 18% of predicted. And I just want to be sure, well, it's not ambiguous, but it comes as a surprise. So you might have said that you thought this was multi-compartment, but if there's a vascular element, he shouldn't be walking 512 meters, although he does desaturate from 95 to 87. So that persuades me most of the DLCO is ILD, but there might be some vascular signal on top. Secondly, you're behaving in a rather indolent way, and that's important in view of what one might say about the scan. So over a period of 2.5 years, the DLCO that was 4 out of 5 in severity has become 5 out of 5, and most people die with a DLCO of 12%. And so he's traveled 70% of the way from 2022 to death based on the current DLCO. So I'm also getting a message, you need an intervention. Now, you need an intervention. The nature of this decline is multi-compartment, I think, because the FVC you're losing maybe, let me just do my maths, 15%, but the DLCO you're losing 60%. So I think there might be a bit of secondary pH starting to happen, but not enough yet, possibly, to give you full-blown pH. So this is a bad news serial profile. He may think that his symptoms are not changing a lot and he's worried about side effects. I would be saying to him, are you sure about that? Now let's go to the scans. There's a familial issue. So immediately, whatever you see on the scan may be atypical.
Yeah.
Sarcoid may behave.
Asmita, scans?
Yeah.
In a usual way. Now I can see, wearing my rather tatty radiologist's hat, thank goodness Marvin isn't here, I can see some features there that make you think about sarcoid, for sure. But what I also see is that when you look at the distribution of fibrosis, you are aware of a group of patients that have a sort of fibrotic IIP overlap. And as you go down into the bases of at least one of the scans, you are seeing the worst fibrosis in the lower zones and subpleurally. And I do think these cases can have a more progressive course. And if you're going to pick a therapy, antifibrotic therapy would be the order of the day. Now, I think we've got to keep in mind with the family.
We can't hear you, sir. What happened?
Can you hear me now?
Yeah.
Yes, yes, yes.
Okay. With the family history, you can't look at a CP pattern and be too dogmatic about the pattern, because a family history will often go with slightly weird features on a scan. You also know that if it is sarcoid, it's probably going to be more aggressive sarcoid if there's a family predilection to fibrosis. So I suspect that this is a form of immune dysregulation in the background. I can see why you might say sarcoid, but you've also focused on high ANA. And if we're trying to say what is the big picture management, I actually don't think it matters too much if you're saying the immune dysregulation element here is sarcoid, or you're going for that highly unsatisfactory entity called IPAF. Now, IPAF is best viewed as a quick gin and tonic for the clinician that doesn't like uncertainty. Basically, it's a research statement, but it was put forward in such a way that it has the features of a full-blown diagnosis. Clinicians don't like uncertainty. They grasp at certainty if they get the chance. And so many clinicians diagnose IPAF much as an alcoholic makes a beeline for the drinks cabinet. Basically, a form of CTD is perfectly possible, isn't it, Sujit, whether we call it IPAF or not? And I think my management would cover both scenarios. I would say that you might have immune dysregulation driving this, but you might have low-grade IPF-like pathways. And so I'm not sure, since the goal is to stop this getting worse, that you use only one strategy and take the risk you're not covering a key pathway. So to sum up, I would be telling him that this is looking grim, even if he thinks that actually life's not too bad, and that he would be making a choice that he wants to avoid side effects, but in so doing, that is very likely or may well radically shorten his life expectancy. I think I would say that the balance of a form of immune dysregulation and a profibrotic epithelial fibrotic IPF-like pathway is virtually impossible to call here. But I don't like a lot of immunosuppression with a family history, and I think I would go with a gentle approach in the background. I'm fairly confident that antifibrotics will be a good thing to have for either of these scenarios. Let's suppose it's all immune dysregulation. I still think an antifibrotic drug is going to have a benefit. So I would be saying antifibrotics are first priority. I think with that DLCO of 18%, you can't possibly do a lung biopsy. And I think the chance with a PET scan of finding that you've got sarcoid signal outside the lungs you can biopsy probably isn't very high. So I think I would be empirical here. Because even if you found sarcoid with a family history, it may be sarcoid that behaves like a non-sarcoid disease. So it's, we're grasping, we're shadowboxing, I acknowledge that. But everything we do for diagnosis is to get the best sense of the natural history and treat, of course. So this is one where I'm going for a shortcut, that this could be driven by immune dysregulation in part and IPF-like pathways in part. It's a bad situation. It's getting worse. His DLCO is 18%. So actually the best is to cover both pathways. You can work backwards to a diagnostic label from that, I suppose.
Sure. No, so antifibrotic, I will convince him for. And the only thing that with this ANA positivity and the glaucoma, I wanted to know from Mithun and you, how much should I push him to take steroids? He has very high reservations, and his wife came back to me with him, of course, and said that he just doesn't want to lose eyesight in the only eye he has. Though the ophthalmologist said, you can go ahead with it, I'll monitor your IOPs, and it'll take at least 10 or 15 days for IOPs to go up once you start steroids. That was the ophthal's opinion.
I'm just not sure I would be talking about steroid as opposed to a non-steroid approach, to be honest, but I'll let Mithun actually speak to that.
Okay. Yeah.
Sir, what about the ANA appears very strongly positive. 1:1000 is a high titer.
Yes.
What's the ANA profile?
So nothing's come on that. Nothing's come. We repeated that. Nothing came on the profile. It was just a high ANA,
That means there may be some autoantibody which is not there in our usual ANA blot.
Yeah. So that's where, I'm so much autoimmune flavor in the disease. And I didn't think of what Athol mentioned about, maybe putting him on methotrexate or mycophenolate.
Well, I think we've got to learn from rheumatologists in their movement away from a steroid-based approach.
Yes.
And I think we absolutely have to learn that. We have to apply this in sarcoid in general, and we have to apply this across CTD-ILD. I'm attacking IPAF, but I'm not attacking a multidisciplinary approach, which is not what IPAF is. That's tick boxes. A multidisciplinary approach where you think it's a form possibly of CTD-ILD, and you've got to cover that possibility. And I would say we've got ample support that higher dose steroid is bad news if you've got UIP-like pathways. We've got rheumatologists moving away from a steroid-based approach across their diseases. Mycophenolate might not be such a good drug for sarcoid.
Yeah.
Methotrexate is an interesting one because we don't believe it drives chronic fibrosis anymore, but it can cause an acute inflammatory response, which is much less frequent. But if you're starting with a DLCO of 18%, this much less frequent inflammatory effect of methotrexate could be a fatal event quite easily. So I think I might be saying think about azathioprine here, because if you look at the panoply of drugs you might use in sarcoid, methotrexate and azathioprine are probably similar in their efficacy. Methotrexate seems to be all the rage, but azathioprine is a perfectly acceptable substitute, and it doesn't have this rare lung toxicity. So on balance, I would not use steroid here. I think his eyes are enough anyway.
Yeah.
And besides, he's not going to do it, is he?
Yeah, he's not. I think that he's pretty sure he doesn't want it. And azathioprine, fantastic. I mean, that's why I wanted to bring this case to follow up, Asmita, with Athol there.
Yeah. But I didn't get why acute inflammatory response is going to be bad for him. Why not methotrexate?
No,
because
it could worsen
he
it.
has a DLCO of 18%, and actually a DLCO of 12% is effectively zero.
Okay.
I haven't seen too many people alive with a DLCO below 12%, and his 18%. Now, I don't know if some of that limitation is pulmonary vascular. I suspect that's kicking in, and it might be there really is a CTD element here, and there really is a bit of multi-compartment going on. You can't be sure of that. It doesn't matter in a way what's driving the DLCO. He's only 6% higher than a dead person, basically, on that DLCO. So if you get an acute inflammatory reaction with methotrexate, that's going to be a disaster.
Yeah.
Okay, got it. Mithun, this anti-KU and all are paraneoplastic, isn't it?
KU is not paraneoplastic. It's a myositis associated.
Myositis.
And systemic sclerosis also you can get.
Okay. Okay, I think that's it. Thank you so much,
Thank
everybody
you.
who has joined from that side. And yeah, we extended 6:33, but Bhavin sir is not there and Aparna is not complaining, so we are happy.
Thank you, Aparna.
Thank
Thank
you.
you. Thank
Thank
you,
you,
Aparna.
Aparna.
Really.
Thank
I'm
you
sorry
so
that
much.
Bhavin isn't here because I would have liked to hear his reaction to the BT impressions from Australia.
Yeah. He told that we should do a PET CT and we should decide for biopsy. That is what the last discussion was about. That you covered that PET CT is not going to give us any more idea. So the discussion was about PET CT.
I don't think it will. And my worry is even if there's sarcoid there and you prove it, it's sarcoid with a familial twist and a hint of a UIP-like pathway mixed in. So, and you're going to cover a form of immune dysregulation anyway. Right. So I think that you're almost delaying making a decision. And look, the only utility of a diagnostic test is to reduce confusion. E.J. Potchin once said that, and I think it doesn't say it all, but it says a great deal. I'm not sure that a PET here will necessarily reduce confusion.
So basically, can we label this case as a PPF, like progressive pulmonary fibrosis?
Well, it is progressive. It is fibrotic. It's in the lung. So it's progressive pulmonary fibrosis, I guess.
I mean, whatever the IPF, PPF.
Yes. Yes, Aparna. I would. The only thing is the patient would argue that he has hardly lost lung function. I mean, the values are not too bad and he's not symptomatic. But
I would say the DLC are going down from 28 to 18%. I don't know what lung function loss is, if that's not major loss.
Yes.
It's not understanding.
He felt he was as good as he was 3 or 4 years ago. So yeah, I think he needs to understand the seriousness of his lungs.
Sure.
There's no way that last DLCO was done at a time of a minor chest infection, was that? If he's going to be very forensic, well, yes, you won't repeat it then. Okay.
Okay. Manish, we are offline, right? Thank you. Yeah, thank you so much. Thank you, Professor Wells and Rajan.